So welcome everyone. Thank you for joining us today. My name is Jackie. I'm a member of the ECHO team, and I'll stick around throughout the session to make sure we don't have any technical issues and make sure our recording is going well. A few quick announcements. Please put your email address into the chat. We need that, especially if you are going to be claiming any type of medical education credit for participating today. We want to make sure that you get the evaluation and are able to claim those. We ask that you stay muted unless you're speaking, but you're also welcome to use the chat. Feel free to use your webcam. We are recording this session for educational quality improvement purposes, and Dr. Farouk will be sharing the recordings afterwards. In the spirit of ECHO's I'll Teach, I'll Learn approach, feel free to be on a first name basis if you're comfortable with that. Also a reminder that during the session, Dr. Masud is providing the lecture today and is willing to address short questions throughout the lecture. So I believe Dr. Farouk will be monitoring the chat. So if you have questions, feel free to place them in the chat during the session and during the lecture. And with that, I think I'm going to stop talking. I'll turn it over to Dr. Masud and Dr. Farouk. Dr. Masud, would you like to try to share your screens, your slides?
Sorry. Okay. Can everybody see that?
We're seeing your slides. Just go into slideshow and I think we'll be good.
Okay, slideshow.
It's in the top bar. It says slideshow. Or maybe you have to hit the enable editing first and then hit the slideshow. Oops, sorry. Something happened. You have to do it again.
Okay, let me do it on that. Okay, so this slideshow.
CLS has been on call too long.
Yep. Yeah, looks like I am. Looking at the slideshow. Share screen. Okay. Share.
Okay.
Not even now?
No, it looks good.
Okay.
You can start with the.
Okay, so so we're going to talk about this thrombotic microangiopathic topic. So before I start, let me say a few things again. I will try to keep it a whole discussion and presentation in an hour. Maybe you can go a little bit longer, but not too long, because your time is precious. I'm on call, so let's finish it 1 hour or 1 hour 15 minutes. At the same time, I'd like to make it more like interactive. So if you have a question, please interrupt me right there where you have any question, and keep your question and your discussion very brief. We can talk a bit longer at the end. So Dr. Farouk is the moderator. He will keep checking the chat room, and if you have a question, you can type it there, and he will ask the question, and we will all share. And I like to share your experience also, because TMA, different people have different experience. So please don't hesitate to share your experience in managing this condition if you have. So TMA is basically a condition which is in where there is a microangiopathic hemolytic anemia. And there's a thrombocytopenia with most of the time you have acute kidney injury, and there's negative Coombs test. And when you rule out other condition which can lead to this condition, when there's a thrombocytopenia, hemolysis, and acute kidney injury, like lupus and DIC or HELLP syndrome, those are secondary causes of TMA. So we will talk about mostly primary causes of TMA today, just to keep it a little bit concentrated on that particular topic. So thrombotic microangiopathy is a specific pathological lesion in which there's an abnormality in the vessel wall, and the capillaries lead to microvascular thrombosis. So when the thrombosis occurs, narrowing of the lumen of the blood vessel, and with the blood has to pass through that, and that would happen, then hemolysis happen, and we will talk why this narrowing happened, why there is a thrombosis happens. So again, there's a three primary condition we're going to talk about called TMA syndrome, like the Shiga toxin related hemolytic uremic syndrome, or complement mediated TMA, or TTP. And all these conditions, when you see their blood smear, you will see that there's schistocytes, the cells are broken cell. There's a very, not almost 100%, that's a basic condition of that particular disease. That all TMA, you will see that schistocyte. Without schistocyte, that's not TMA. So again, thrombotic microangiopathies, as I said, a lesion of the arteriole and capillary vessel thickening, and that can lead to thrombosis. Thrombosis can narrow the lumen, and when the blood passes through that, that lead to hemolysis. So TTP could be hereditary, or most of the time it's acquired, immune-mediated TTP. While hemolytic uremic syndrome, which is two types, one is used to be common, still common, but used to be the only type of hemolytic uremic syndrome that was related to some infection, most of the time E. coli producing Shiga toxins. And then later on, they found out that some patients had the same presentation without having that diarrhea and that toxins, and that started with calling that atypical HUS. Later, we found out that is because of complement mediated. So now it's called complement mediated HUS. Again, this different type of different reason causes of HUS. First, there's a Shiga toxin associated because of Shiga toxin. And there's another toxins related is neuraminidase caused by Staphylococcus pneumonia that cause also this condition, which is very rare though, very rare. And atypical uremic syndrome, familial, there's a mutation of the many complement factors, and that can cause like uncontrolled activation of complements that causes atypical HUS. And it could be idiopathic, but sporadic, or could be familial. Most of the time is familial. And there are conditions which can trigger the genetic tendency to have this disease, and different triggering factors. Most important one is pregnancy. And also there's a HELP syndrome, there's a transplantation de novo, atypical HUS can also found. So these patients has some mutation to begin with, but mutation only is not enough to cause the clinical picture. Some triggering happens and then the disease happens. And TTP is the same thing. There's a, I'm going to talk a little bit more that the pathogenesis of that, how the TTP happens. Basically, there's a protease enzyme called Adams TS13 that actually prevents the formation of TTP. When there's either absence of low level of that enzymes because of congenital, or there's acquired, most of the time it's acquired, 90% of the time it's acquired. There's antibodies against that protease that can cause TTP. And there's some other condition which can cause TTP, like very, very rare cobalamin C deficiency. And not so uncommon is drug-induced, and diplopidine and Plavix are common medications. And when there is a homologous stem cell transplant or bone marrow transplant, after that it can happen. It all happened because there are some antibodies are formed against that Adams TS13 13 enzyme. Malignancy can cause that, or HIV can cause that. So these are common lab findings in this condition. There's a thrombocytopenia that also give you some indication at which condition we're talking about, either it's HUS or TTP. The main difference is that when there's a TTP, there's a very striking thrombocytopenia. Most of the time, you will see that platelets count is less than 30,000. While in HUS or complemented mediated HUS, thrombocytopenia is mild. Many times you see more than 100,000 platelets count. But microangiopathic hemolysis is always there, and you will see always increased tissue peripheral smear, negative Coombs test. And another finding is that all the PT, PTT, INR fibrinogen level are normal. This is a differential point from DIC, and in which condition there's an abnormal PT, PTT, or fibrinogen or D-dimer, while in TTP, these are normal level of those. And renal involvement happens more commonly in HUS and more severe also in HUS, and it happens less severe in TTP. That's a differential point again between HUS and TTP. I'll talk to you why it's more important, very important to differentiate whether we're dealing with TTP or we're dealing with HUS. So again, HUS, more severe renal involvement. In TTP, less severe renal involvement. In TTP, more severe thrombocytopenia. In complement-mediated HUS, is less severe thrombocytopenia. So this is actually a study that says in France, their registry, they find out it's a serious disease with the consequences. And they collected a record from 4 hospitals, 564 patients, and they said that primary TMA, which we're going to talk about, is less common. Secondary TMA, pregnancy, infection, malignancy, these are more common causative factor in forming TMA. So primary TMA, the TTP 3% in their record, and HUS 3%. And second TMA, you can say pregnancy is the most common factor, then infection, drugs, and cancer. And Shear toxins, pretty common in the primary TMA. And out of those patients who had, close to half of them, they end up need to receive a blood transfusion. And they have 94% of them, they receive plasma exchange, 15% ended up in dialysis, and majority of them, 11% of them have cardiovascular, and 4% have neurological complications. Any question up to now? I mean, just checking, I want to, if not, then we can move on, and please feel free to have any question, ask any question if you have so far. So this is basically briefly how you approach this condition, TMA. So if you have a patient who has decreased platelets count, increased serum LDH, which is a sign of hemolysis, and fragmented erythrocyte or schistocytes, that is TMA. Okay. Then you go by history. If patient has diarrhea, and you check the stool test, and if it's positive for Shiga toxins, that is Shiga toxin E. coli induced HUS. Majority of them, they recover. Some of them, they go.
Can I make a very quick comment?
Sure.
I think we need to parse out some, just semantic nuances. So what we have in this box that you're showing, decreased platelet count, increased serum LDH, and fragmented erythrocytes, that's actually microangiopathic hemolytic anemia. TMA is the commonest cause of microangiopathic hemolytic anemia, although there are conditions in which you can see microangiopathic hemolytic anemia without TMA. And mutatis mutandis, there are conditions in which you can have TMA, but may not have microangiopathic hemolytic anemia. So I just wanted to make that semantic nuance a little clear.
Thank you. So when you're TMA, first of all, basically TMA can be, as I said, that other secondary causes more common. You make sure we're not dealing with pregnancy, we're not dealing with DIC, we're not dealing with an infection or malignancy or lupus. So if that has been ruled out, then we left with the TMA, primary TMA. In that case, you go by history. Patient has history of diarrhea, or patient has Shiga toxins positive, then patient has Shiga toxin E. coli induced HUS, and that most of them they recover. Many of them HUS, and some of them good number of them who develop HUS, they end up having renal failure, but many of them also improve, particularly in children. In adults, many of them, a good number of them, about 12% or a little bit more than that, they end up having end-stage disease even after treatment. So we'll talk about treatment. So then if you have TMA and you ruled out there's no history of any diarrhea, and then you will see if you're able to see that Adams TS13 activity. If it's less than 10% activity, then it's TTP. So again, when you have TTP and the Adams TS13, which is a protease, and its activity is less than 10%, then you able to check if anti-Adams TS antibodies are present. That is acquired TTP. But if there's no antibodies, then it's a congenital absence of that protease. So if that congenital absence protease, the treatment is only plasma exchange or infusion to replace that protease. But if it's an acquired TTP, then again, plasma exchange, not transfusion, because you want to take out that antibodies and also replace with those protease, and also rituximab to suppress the formation of those antibodies or other immunosuppression. So then if there is no history of diarrhea, so history doesn't suggest E. coli toxin Shiga induced or Adam 13 activity is more than 10%. So it's neither Shiga induced HUS, it's neither TTP, is basically complement mediated HUS. Then we talk about the treatment for that. These are the secondary cause of TMA, pneumonia infection, cobalamin deficiency is very, very rare, and drugs, cancer, HIV, or systemic diseases. These are basically a biopsy finding of that condition. Basically, this is a peripheral smear, which you can see lots of schistocytes, fragmented RBCs. And these are different picture of the glomeruli. You can see that most of the time you see thrombus and fibrin, all those large thrombus. And these are arterioles. You can see that very narrow lumen of this arterioles or fibrinolytic necrosis. So that will you see predominantly thrombosis. And that's the electronic microscopy of the glomeruli. You can see that this is the endothelium is detached, and there's a fluffy material accumulates that here, and that's like separated from basement membrane. And then with continuation of this process goes on, there's a basement membrane thickens and this disappears. This is basically not specific for any particular TMA. This generally happens pretty much all the condition which can lead to TMA, and there's a renal involvement with that. It doesn't have to be HUS, either HUS or Shiga. Toxins induced to HUS or even TTP when it involves the renal or the condition which are even secondary TMA, this picture comes in. Look at the arterioles, all lumen is narrowed, nothing much left, very, very small lumen. This big artery, again, the purification of the intima, and very small lumen. So let's talk about the Shiga toxin again. It's producing Shiga toxin producing E. coli. There are multiple strain of E. coli produce that, but most common one is this 0157 Shiga toxins. So the Shiga toxin GI tract of the ruminants, mainly cattle, that's a reservoir. the cattle doesn't get infected, but it can pass the toxins with food to human beings. It can pass by beef and not clean vegetable or fruit, milk. So this is ingested 3-4 days, abdominal cramps and non-bloody diarrhea, or sometimes bloody diarrhea, which happens after a couple of days later. And then about 95% of the infected people, they improve, but 5% become HUS. And from 5% of HUS, then most of them, they recover eventually, but some of them, they have long-term consequence, either with end-stage kidney disease or CKD or chronic kidney disease. Few deaths now, but still happen in many outbreaks. Actually, there was an outbreak in Germany about 10 years ago. There was a different strain, and I think about out of 900 people, 58 died actually. So with toxins, they bind to GB3 receptor. What happened then? Let me go to the next slide and explain this better. So this is the toxins, which is goes to intestine. From there, from the person's intestine, it goes to the absorbed into bloodstream. It's taken up by leukocytes, and then goes to different organs, including kidneys, when their toxins are released and are taken by endothelium, and over there into Golgi apparatus, endoscopic reticulum, and basically they interact that inhibit the synthesis of the protein. That's why the cell death occurs. At the same time, it activates other pathway, some complement activation, and then can lead to thrombin and thrombus formation. And that can lead to microthrombi and occlusion of the arterioles and capillaries. The diagnosis is detection of E. coli in the stool. Clinical course, after exposure to these toxins, majority of people, they develop hemorrhagic diarrhea, 3% to 9% in sporadic infection, and 20% epidemic progress to HUS. And then about 25% of patients with this Shear-induced HUS have neurological involvement also. And in prognosis good in childhood, then most of them, they recover. Therapy basically is supportive therapy. No need to give in any anticoagulants because that can cause bleeding, and anti-motility agent should be avoided because that prolongs the course of the illness. And this is an important thing, that the antibiotic should not be given in this condition unless some specific reason, and because in children, the gastroenteritis may increase the risk by 17-fold HUS if you use antibiotics. Antibiotics also cause injury to bacterial membrane, which release of more toxins with that. Particularly antibiotics like quinolone, trimipramine, and this I think antiprazole medication. These should not be given. Although azithromycin has some protective role, if indicated, that can be used, particularly that pneumococcus-induced HUS. Although if it's formed by Shigella dysentery, in that case, antibiotics has some role. So complementary mediated hemolytic anemia. Basically, this is genetically determined dysregulation of the alternative pathway of the complement system. If you see their complement level, most of the time, about 50% cases, C3 level is low with normal C4 level. That shows that the alternative pathway of the complement, that is like overactivation of that. This is just a brief introduction of the complement pathway. So there's a three-way of activation of complement pathway: classical pathway, lectin pathway, and the alternative pathway. So all lead to C3 activation from CA, then the factor B, combine that, and that lead to this combination, which activates this convertase, C3 convertase, activates C5, which start another cascade, which lead to this membranous activating factor, lead to C5, lead to C5b, then C5b, 5 to 9. That eventually activates does it affect to different organs. So in this whole pathway, this is closely regularized, because if it's keep on going too active, then can cause disease condition. So there are some factors which control the overactivation of that, and some factor which actually helps in activation. So it's a very delicate balance between activation and inhibition. So keep it under control. If that dysregulation happens, that leads to complement-mediated HUS and some other condition also. So basically, the alternative pathway is always in a slow active form. Okay, and that when this some dysregulation of activity of this alternative pathway happens, that leads to complement-mediated HUS. So here's again same description. So this is alternative pathway, this classical pathway, and lectin pathway. They combine and they call this 3B, lead to this, and that start amplification loop that keep on increasing the activity of that. And this lead to C3 convertase, leads to activity to next to activate T5. And here's when we talk about this treatment of that, the eculizumab, it protects or it stops this cascade right here. And so stop from keep on getting activated from here. If it's not there, then it keeps going this whole cascade and membrane attack, and then different activities at the same time form thrombin formation, and then can cause the occlusion of the arterioles and blood vessels. That is one effect. It can also affect the endothelium. So all different activity can happen with the overactivation of alternative pathway, which can lead to overactivity of the complement system. So there are some important factors which you need to remember in pathogenesis of complement-mediated HUS. So factor H. Factor H is one of the regulatory factor in the alternative pathway, the complement. And when there is a mutation and the activities is less, factor H, that is the most common cause of complement-mediated HUS. So there's a mutation to complement factor H. So this is a common cause of end-stage kidney disease. I think this is figured out before we had this complement inhibitor. Like it used to be very common cause of death and disease. Still not uncommon, unfortunately, but much less now. So these are few affected genes which are mutation of that, causing that complement-mediated HUS. Most important is complement factor H mutation. Then MCP, this is a membrane cofactor protein, and then complement factor I. So complement factor H, MCP, and complement factor I mutation, that's the most important factor. There's some other also, but much less common.
Dr. Vasif, could you please mute your mic?
Okay, so these are, so HUS, complement-mediated HUS, most of the time is genetically determined, and they have mutation happens, and then some triggering factor which can lead to disease. But sometimes there's acquired causes also when there's antibodies are formed against those factors which regulate the complement system. There's some antibodies against factor H13 or factor I. Those are some acquired causes of complement-mediated HUS, which is much less common. So TTP is most of the time is acquired, or HUS, complement-mediated HUS, most time is congenitally or inherited determined. So treatment for complement-mediated HUS, when we talk about one of the breakthrough treatment came out is Eculizumab. Eculizumab is basically recombinant monoclonal antibodies, which binds the factor C, and the complement 5, and blocks the further activation of the system, of the cascade. So it's very effective, and if given the right time, right dose, it's very effective. Is it available in Pakistan? Or?
No, it's not available.
So this is given every 2 weeks on a long-term basis, and this is another one which is a longer version of like this same thing like C5 inhibitor, which is a new one. It was, I think, approved in 2019, and it can be given every 8 weeks. I have not used it as yet, this medication yet. So plasma exchange is another treatment for complement-mediated HUS. And some places where Eculizumab is not available, this is the main treatment for that. And this is also treatment for TTP, plasma exchange. A kidney transplant is also needed when the patient has. But kidney transplant in complement-mediated HUS is not the straightforward answer, because it depends on what factors was involved. The recurrence rate is very high, particularly if patient has complement factor H mutation, then it's almost 70–80%. There's a failure of the transplant. And the lowest incidence is when there is a MCP, membranes factor protein that is involved. So let's talk about TTP. So TTP is mechanism is here. So this is a endothelium, and from endothelium, this large one-Williams factor is produced when there's a small shear stress on the arterioles, particularly small arterioles or arteries. And this release is a long one, but this is also, whenever the release is cleaved by this enzyme, ADAMS13, ADAMTS13. So it's one factor is cleaved and is small. So when it remains small, then there's no accumulation of platelets on that. But because of, if this enzyme is deficient, like here, and there's a shear stress on the arterioles, this one-Williams factor will be released, and a pretty long one. And this ADAMS13 is here, but it's blocked by antibodies formed, and it's not active. And then you can see that this one-Williams factor can become very long, and that attracts other platelets, and that's why it formed the occlusion of the blood vessels, and then all cascade starts. It also involved many organs. Most common or most serious one is when the neurological involvement, cardiac involvement, GI involvement. So this process is generalized many parts of the body. Same in the picture like here. You can see that this is normally it happens when this is formed one-Williams factors. It's cleaved by this enzyme. But when this enzyme is blocked by antibodies, or its production is less because of inheritance, then you keep on for longer factor, and that can attract many platelets, and that can cause the occlusion of the blood vessels. So that's called TTP. So congenital, that's common. Acquired, most of the time, 90% time, there's acquired antibodies produced. Again, this ADAMS DS13, DS13. Other causes are, these are drug-induced, common. Cobalamin C deficiency is very uncommon. Malignancy is common. HIV. So these are conditions which can form the antibodies against this enzyme and can lead to TTP. So same thing we just spoke about. So about 5%, then the genetic deficiency of that enzyme can lead to this condition. So it's a very serious condition and can be managed if diagnosed and picked up early. So this is very important to diagnose this patient very early. And when you suspect a patient TTP, then plasmaphoresis, plasma exchange, should be done within 24 hours. So what you do that when you have a patient who has TMA, so just to like differentiate, when you have HUS, TTP is described to have HUS has less severe thrombocytopenia and more severe renal involvement. So, and neurological involvement are more common in TTP, and GI involvement is more common in TTP. So TTP treatment is plasma exchange, steroids, and rituximab. So this is summarize the management of TTP. So here's, we just spoke about that deficiency of atom DS13, and then can lead to inclusion of the ischemia of the many organs. When you diagnose by the activities less than 10%, this enzyme activity, and then can lead to TMA, TTP. So in that case, the plasma exchange is the treatment for that. Sooner you start is better. When there's a not clear as a TMA or HUS, you start with plasma exchange, and later if you found that the atom 13 activity is more than 10%, that means TMA is not the TTP is not the diagnosis, then you can stop Plex and you can go ahead and most likely HUS, then you can start treatment for that. But plasma exchange should be started when you think about patient has TMA, either a TTP is not ruled out. So treatment is starting Plex and starting every day until you count is more than 150, or when the condition improves clinically. At the same time, you start rituximab. You typically give 4 doses, weekly doses. And this medication, the new medication, is actually blocks the platelets accumulation at the Von-Wheeling factor. This is a new medication I've used. I mean, I'm involved in the patient, 2 patients who were given that, and in one it worked, and second patient did not work, and the patient died eventually. It's extremely expensive. I think you give for 1 month, and every day is about costs by 8,000 or 9,000. So it's I've used twice, so very new. And anybody else has experience of using this medication so far? Or yes. So basically treatment is plasma exchange, rituximab, and steroids. These are 3 treatments for TTP. So when you have condition, when many times it takes time before you have atoms TS13 level activity level comes back after a few days, but you don't have time to decide. Then this is a plasmic scoring system that was developed a few years ago, and it's give you an idea that what you're dealing with, whether this is a TTP or it's not TTP. So this, you can see that if platelet count is less than 30, that's 1 score. And there's evidence of hemolysis. There's no active cancer, no other solid organ transplant. So other secondary causes are ruled out. And the creatinine is less than 2. So if you have this high score, 6 or 7, that 90% chance you're dealing with TTP, and you go ahead and do the treatment for that, steroids and plasmaphoresis, plasma exchange. You don't have to wait for times 13 to come back. That's very important, because the time is the very important that condition when you're dealing with that. So the same thing, that is a very good predictive value it has, this plasmic score. This is actually a very like a small version of that same idea, that if you have just 3, like creatinine is less than 2 and platelets are less than 30, and there's a positive ENA, because when there's a autoimmune condition, there are more chances of patient had TTP. That also likely that you're dealing with TTP, and you can go ahead start treatment with the plasma exchange. So as we said that we need to start plasma exchange, daily plasma exchange, if we have platelets more than 150,000. There's a patient who have frequent relapse of TTP. In that case, you have to give a prophylactic plasma exchange every 2 to 3 weeks. And steroids also given to suppress the formation of the antibodies, and depends on patient condition. If patient is very high risk, you give high dose like bolus, and then high dose of prednisone. You give 1 gram for 3 days, and then 1 milligram per kg per day for 4 weeks. And after that, when the condition improves, you slowly taper off. And we spoke about rituximab. We begin for 4 weeks, weekly dose, and this causes remission commonly, and remission could for 9 months to 4 years. And in some condition, you give rituximab to prevent the relapse if you have history of frequent relapse. So basically, take-home message that when you have dealing with the MAHA, the microangiopathic hemolytic anemia, you have thrombocytopenia and AKI, and there's a negative CUM test, and secondary causes are ruled out. Then if you have very low platelets count, commonly less than 30,000, and creatinine is not that bad, like less than 2, and there is also a neurological system involvement, and Adams activity 13, Adams 13 activity is less than 10, that's TTP, and treatment is plasma exchange, steroid, and rituximab. And when you're less severe thrombocytopenia, most of the time platelets are more than 100,000, but severe AKI, creatinine is 5, 4, very commonly we see, or patient end up in dialysis in shortly in a week or 2. And you check Adams TS13 activity is more than 10%, and less severe systemic involvement, that is a complement mediated HUS. Obviously, if there's no stiff diarrhea or Shiga toxins, then you're dealing with the cell-mediated HUS, and treatment is Rituximab, and when it's not available, then steroids and plasma exchange. And obviously, when you're dealing with the diarrhea and Shiga toxins HUS, then basically mainly supportive treatment and avoid antibodies. Okay, time to wake up. So I leave some time for any discussion, questions from here.
Thank you, Dr. Masud. So I know Adil, he has some comments. So maybe Dr. Adil Manzoor, do you want to just share your comments with us about your experience?
Yeah, that's fine. Now, I just wanted to emphasize on the plasmic score. In our setting, sometimes we get this ADAM-TS levels, and most of the times we don't get this ADAM-TS level. So when the suspicion of TTP is very high, this plasmic score in our setting, in a Pakistan setting, will be very important to initiate the plasmaphoresis. And we initiate the plasmaphoresis anyway before we get any ADAM-TS levels. And the number 2 point I wanted to emphasize that the steroids and this rituximab will work only in acquired setting of TTP. And as we know that the acquired TTP is much more common than the congenital TTP, where amounting to about the 95% of the cases. So these 2 points I just want to make sure. Otherwise, it was a very fine, clear, crystal clear concept by Avais. Great. You did a great presentation.
Thank you. Thank you.
There is one more question in the chat. Is there any specific cutoff value for peripheral schistocytes to differentiate from secondary TMAs?
I mean, no, schistocytes are pretty much same. I think there's some condition you have more schistocytes, just based on schistocytes. I don't think that you can differentiate whether it's you're talking about DIC or you're talking about TMA. You have to have other factors also. Like if you want to differentiate whether this is a DIC, as I said earlier, that the D dimer will be high, then the TTP, INR or PTT will be high. But if at least I don't know that is the numbers of schistocytes that can differentiate between secondary and primary TMA. Although theoretically, if you have cobalamin deficiency, that's extremely rare. That has the condition in which you see most number of schistocytes, because almost like a big majority of these cells you see in smear will be very delicate or fragile.
Do we have any pathology colleague who can comment on this question as well and share their experience, because they probably are seeing more hematology slides and other conditions? So maybe a practical input. Do we have anybody from pathology today? Probably, I'm looking at the list.
Again, you cannot say that, okay, this is like this many schistocytes I can see, and this is not TMA. You don't want to make that, decision, just number of schistocytes. Yes, schistocytes has to be there, otherwise not TMA.
No, I think we got similar opinion from Adil as well. And then I think
Can I make a
he
comment?
wants to say something. Yeah, Dr. Tariq, you want to say something?
Yes, please. Assalamu alaikum. I think you're absolutely right. The number of schistocytes don't matter if you have the whole picture there. However, it's been written in different books, and recently I was reviewing somewhere. It was written if you see more than 1% schistocytes in a per high power field, that should raise a red flag. And then you should look at the whole picture, as you have already very nicely explained.
Thank you. Ali, you want to go ahead and
yes.
ask?
Yes, thank you. The thing is that we do not commonly have these tests to differentiate between different kind of HUS, the infectious variety and the complement mediated one. And so the problem, especially with children, is that when they come with the hemolysis and acute renal failure, you cannot distinguish between the infectious variety or it's the complement mediated. The history of diarrhea itself is never enough. There can be other infections, especially the pneumococcal infection, which is very common now. And in those infectious varieties, you are again not sure if you need a plasma exchange or not. So in most of the developing countries, the problem with the treatment of this disorder is that you have to start empiric treatment with plasmaphoresis or plasma infusions. And then you work your way through the course of the illness and see if they start recovering, then you withdraw your plasma infusion. Otherwise, you have to give plasma treatment. Now, the difference between plasmaphoresis and plasma infusion mainly is the cost. One session of plasmaphoresis in Pakistan may cost up to 75 to 80,000 rupees. And one plasma infusion would be only few hundred rupees. So places where there are plasmaphoresis is not available, the message that we usually give is that you at least start with plasma infusions. And that in itself, it has been, there are very few controlled trials on this, the comparison between plasma infusion versus plasmaphoresis. Even in the complement mediated ones, if you have an antibody against a factor, then the chances of responding to plasma infusion are less. But if it is a genetic defect that was there, but something has triggered it, and then you just replace that complement factor with plasma infusions, the chances of recovery are much higher.
Absolutely, right. We have to see that. I mean, good physician would see that what is available and what I can do to make the patient better. So if you, whatever your availability is, just act accordingly. And if you don't have a facility for plasma exchange, uh, I think a plasma infusion is a good way to start with. And particularly if you're dealing with the recurrent episode and most likely patient has inherited deficiency of Adam's TS13, then infusion is the treatment, not the exchange, because there's no antibodies to take out. It's basically you have to replace that protease.
I think of as what you wanted to say was not inherited, inherited Adam's TS protein deficiency is extremely rare. So when you're talking about TTP and you're talking about acquired TTP, then unfortunately you have to do plasma exchange. You have to take the antibody away. On the other hand, if you have complement mediated issues, gene issues where there is deficiency of a factor, then simple plasma infusion is enough. As Dr. Lainwala pointed out, there's a very small subset, usually if it's a CFHR 1 to 3 fusion, where you may have a factor H autoantibody that is causing the problem. In those cases, also, you will need to do plasma exchange, not just infusion. But if it's a complement deficiency, you can do effusion. And if it, sorry, not effusion, infusion. And if there is the rare TTP syndrome due to Van Willebrand factor protein deficiency, then you can do infusion. But even with complement mediated diseases, when you do plasma infusions, you have to do them persistently, and they are kind of half effective, not totally effective.
Yes, yes, that is very true. Plasmaphoresis, if we give, we usually do it for 14 consecutive days. And then we slowly taper over 2 weeks or so. And then we reduce the frequency to 2 times a week, and then once a week, and then once every 2 weeks. And then we go down to once a month. And then continue giving plasma infusions at least once a month. Till we see some kind of, if they have started to recover their functions in 2 weeks or 3 weeks, then you may safely bring down your plasma infusions. But if not, then in the absence of any definitive diagnostic tests, this is usually a big problem.
In Pakistan, the most important thing to do is to differentiate what kind of syndrome you're dealing with. And I think, especially in a pediatric population, the biggest differential that you have is this infection related or not? And, if you look at the EHEC outbreak in Germany that happened due to those Brussels sprouts, even in those patients, there were some patients who had documented Brussels sprouts related, EHEC related thrombotic microangiopathy and microangiopathic hemolytic anemia, and yet they required eculizumab and responded to it. So how is that possible? It is like in any other infection. If you've got an underlying complement deficiency, maybe some factor H mutation, factor I mutation, MCP, CFHR, what have you, when there is a systemic stressful situation, like we had pointed out, pregnancy is such a stressful situation where you unmask those disorders, right? You unmask your complement mediated HUS during pregnancy or in the purpurium. Similarly, in the middle of a severe infection like that, you can actually precipitate complement mediated HUS, which actually started as an infection related HUS and then morphed into complement mediated, but that is a very small minority. So most infections to the tune of 95 to 98% will get better on their own. Even if they have a thrombotic microangiopathy, they will recover. Some won't, and the people who don't are actually the people who have complement mediated. This is very, very similar to post-infectious glomerulonephritis. Like a huge majority get better, but some don't. And those people who don't get better with PIGN are actually people who have underlying complement mediated issues and actually precipitate C3GN most classically in those circumstances. So some of the infections precipitate those. But once we have gotten the infection related issues out of the way, once we've gotten DIC out of the way, and once we've gotten, autoimmune disorders like lupus, etc., out of the way, then the two big buckets that you have to distinguish are complement-mediated HUS and TTP. And diagnosis of TTP is somewhat of an emergency. The mortality is extremely high. HUS is a slow burn disease. It takes weeks to months for it to develop into a significant syndrome. TTP would kill you in that period of time. And so whenever in doubt, you have to pheres. Now, plasmic score is a very, very good tool. It gives you reasonable confidence. But if your clinical suspicion is, if you're worried that the patient is not going to do well, then in adults, plasmaphoresis in kids is a little bit of a hard thing to do. But in adults, 1 or 2 sessions are not unreasonable till the time you've sorted it out. But in my practice, over the years, I've gotten confident, maybe cocky to a point where I don't pheres, and I get eculizumab started, sooner rather than later if I worry that if I'm convinced that this is complement-mediated HUS. Now, one other very, very important situation that as clinicians we run into all the time is hypertension-associated thrombotic microangiopathy. People come into the hospital, they've got microangiopathic hemolytic anemia, you biopsy them, you find thrombotic microangiopathy on the biopsy. And if you talk to the eculizumab people, they'll say, oh yes, put every one of those on C5 inhibitors. But we all have seen these patients get better with control of blood pressure. And so there again, like the other subsets, like the infection subset, like the PIG-N subsets, there is going to be a subset of patients in the hypertension subset, hypertension bucket, where they would have underlying complement-mediated disorders, but most of them not. So why is it that hypertension produces so much thrombotic microangiopathy? And there's a very, very interesting thing. Avais showed you the classical pathway and the lectin pathway and the alternate pathway of complement activation. Now it seems that there are other pathways of complement activation as well. And one of them is mediated by renin. And renin seems to be a complement, so a C5 convertase essentially in some of these issues. And therefore, with accelerated hypertension and sickle cell disease, two of the highest renin states that you can think of, you see thrombotic microangiopathy very, very frequently. And it is probably because of this that once you control their blood pressure and the renin levels start getting better, you see resolution of the thrombotic microangiopathy. Another molecule that is supposed to not be related to complement, but it is thrombin. And it seems that thrombin can actually act as a C5 convertase as well and generate local complement activation. And just to make things more fun and complicated, there's now this whole new concept of the complosome coming up, the intracellular complement activation, which under various circumstances leads to complement activity in local beds. So this is just a fascinating amount of science. Wonderful presentation of Avais. This was very, very clear and laid open a lot of concepts. So thank you for the effort.
Thank you. Irfan, from question from you. I mean, in your experience, do you stop giving eculizumab at some point? Have you thought about that?
Yeah, so a very interesting point. So I attended an advisory board for Solaris maybe 8, 9 years ago now. And
so just to remind everybody that when we give eculizumab, we give a 900 milligram, weekly, and I think after 4 doses, we give 1200 milligram IV, and then every 2 weeks, supposed to be rest of the life of the patients. But again, there's a controversy whether how long we should be given, and they should be able to stop that or not. So Irfan, please tell me your experience and your thought about that.
yeah, so essentially when I attended that, their mantra was everybody who has HUS, complement-mediated HUS, needs to be on this medicine for life because the risk of relapse is high. But this is a very, very costly medication and costs $500,000 a year. So, people, and plus it's an infusion that the patient is getting on a regular basis. So people have started thinking about why would it be necessary to continue with this medicine forever? So the question to that, I think the insight to that answer comes from what was happening before they got sick, right? So they had this mutation always, it's in their genome, right? And then at age 33, they suddenly precipitated HUS. So why was it that for 33 years, they had no problem, and then suddenly at age 33, they had a problem? And the answer to that is the complement amplifying condition, that there was some sort of stress, pregnancy, infection, severe hypertension, lupus, whatever happened caused them to destabilize the alternate pathway control, and they developed HUS. Now, once you start putting somebody on eculizumab, one of the most important things that confirm your diagnosis is response to therapy. Platelet counts start going up in 3 to 5 days. LDH starts coming down very, very quickly. So if you're not responding that way to eculizumab, you have to question your diagnosis. But in any case, once this happens, if you start the eculizumab at a month when everything is recovered, you'll probably have a relapse. And the answer is, once the endothelium destabilizes, it takes months to years for those systems to kind of reset back to normal. And most people feel it takes about 1 to 2 years for most type of mutations to settle down. So people have started doing that. And once they do that, they still see some relapses even after 2 years. So you have to watch for that. But mostly the relapses happen in very high grade mutations. So if you've got a factor H or a high grade factor I mutations, which we've started figuring out this one's a bad one, then you might need to go longer. But if you've got an MCP mutation, or if you've got a factor 3BB mutation, a factor 3 mutation, then you might actually be able to wean therapy at 2 years and then slowly walk back from there.
So I think in the interest of time, there are 2 more questions, which, if we can address, and then those will be last 2 questions. So one, they are related to transplant. So any of the panelists can answer. So if there is recurrent atypical HUS after transplant due to, and there is either some sort of a genetic factor involved, do you prophylactically give eculizumab or just wait and see for any recurrence? So do you start this at the get-go after transplant, or you just kind of wait some bad things to happen and then give eculizumab? So that's one question. The second question is that it's related to drug-induced TMA, so CNI, Tacro, or the other one. Once you have it, now you treat it with withdrawal of the drug, patients are still kind of in trouble. What do you do next? Do you consider plasma exchange or other things? So who would like to take these 2 questions? Irfan, you want to try first, or Avais, you want to take the question?
Okay, for transplant, I think I would like Irfan to take the question first, and then I'll take the second one.
Okay, so from a transplant standpoint, if you know that somebody's got HUS and they're on eculizumab already, they will continue the eculizumab. If somebody was diagnosed with HUS and they went into renal failure, then depends on what kind of mutations they had. If it was a high-grade mutation, I would put prophylactic eculizumab anytime we get that approved, and we start that at the time of transplant, sometimes even before transplant if it's a live donor and if we know that we're going to be controlling it. There are certain types of mutations, for example, MCP, membrane growth factor protein, CD46. Now, this is a cell surface protein, right? So when you're putting in a new kidney, guess what you're putting in with that? You're putting in a new cell surface with normal or wild type CD46. So it's probably not going to be a problem. So it depends on, what type of derangement you're looking at. Now, a lot of times we see patients who are on their third transplant, right? And so you look at that, okay, one transplant, second transplant, third transplant, there's 2 family members with kidney transplant as well. But it's that, these are difficult diagnoses. And so and they're missed. And so when we look at that, we say, okay, this is going to be trouble. So now complement gene testing is actually not that hard to do. It's cheaper, it's faster. So we actually gene test them. And if we find a high grade mutation, then we use eculizumab prophylactically if indicated. So I'll let Avais take the other one.
Yes, actually, although it's rare that most of the time when you take off this medication, patient gets better. But in certain circumstances when it's not happening, you take the patient as the same as you take the primary TTP. Like there are antibodies which are being produced, stimulated by that medications. Depends upon the medication also. I mean, some medication which are taken off, like quinine, those medication basically, cause the autoimmune activity and cause the antibodies. And those medication, although it's taken off from USA, if it's still being used in Pakistan, so you have to do the plasma exchange to take off the antibodies. Or at the same day, if that is not enough, you have to give some immunosuppressant also to suppress the formation of the antibodies, like steroids or even rituximab. So most of the other medication, they are not immune mediated TPA cause that. And in those cases, you can try plasma exchange, but again, probably will not be effective, but you definitely, this makes sense to try that.
Yeah, so we see calcineurin inhibitor toxicity, which sometimes presents with TMAs all the time. The first thing to do in the post-transplant world is to make sure you're not missing an antibody-mediated rejection, because that's way more common and more pertinent. Once you've excluded that and you're convinced that this is calcineurin inhibitor toxicity scenario, then switching from one agent to another is actually quite helpful. And then the agent that we usually switch to now, previously, there are case reports, you take cyclosporin, convert it to Prograf, and it stabilizes. You take Prograf and switch it to cyclosporin, it stabilizes. But now what we do is we switch to belatacept, which bypasses the calcineurin pathway completely, and it works way better. Now, drug-induced thrombotic microangiopathies are a fascinating subject, or by themselves, because of the explosion of chemotherapeutic agents, not chemotherapeutic agents, but biologic therapies which target the VEGF pathway. Now, just think of this for a second. The shear stress on the glomerular capillaries is phenomenal. The glomeruli are what, 25, 30 grams in weight, and 1.2 liters of blood passes through the gloms every minute. So the ml per minute per gram blood flow of the glomerulus is astronomically high. It's orders of magnitude higher than any other capillary bed. So that's why the shear stress, the shear stress is stress which is parallel to the surface, is extremely high in the glomerular capillary. That is why TMA happens with such alacrity in the glomerular capillary beds. You don't see TMA in the lungs, you don't see TMA in the heart, but you see TMA or TMA in the liver. There's capillaries all over the place, but you see TMA in the kidneys because of this shear stress. And along with the shear stress, the other type of stress that you see in the glomerular capillaries is convective stress. And so both of those things make the glomerular capillaries very prone to damage. And then when there's damage to the endothelium, you run into a TMA type response. And this is why the podocytes produce a lot of VEGF, and that VEGF keeps maintaining the glomerular endothelium at all times, which acts in a paracrine fashion. But if you target that VEGF, then you're going to cause TMA. And so all of your TKIs and your VEGF inhibitors and so on and so forth, which are now cancer chemotherapeutic agents, can cause this. And therefore, the syndrome that you see with these drugs with TMA is very different than the syndrome of the direct endothelial toxic chemotherapeutic agents that you see, for instance, with gemcitabine, where it is a, or mitomycin, it is a syndrome where it happens late with a high cumulative dose, because that's direct toxicity which accumulates over a period of time. With VEGF inhibitors, you can see it 2 weeks after initiation of therapy. Calcineurin inhibitors also are direct endothelial toxic, apart from so the only agent in our transplant armamentarium that disrupts the VEGF pathway is mTOR inhibitors. So there's a lot of fascinating stuff that that is happening on endothelial biology, renal endothelial biology, and its predisposition to develop TMA due to all of these drugs that we are going to see more and more as time comes.
So if on over the years, I mean, cyclosporine used to be more common, and then tacrolimus came. I think after tacrolimus predominantly immunosuppressant, the incidence are less now as compared to what used to be with cyclosporine?
You're right, because we're not running levels as high. So when tacrolimus came out, 1995, 6, something like that, we were running levels of 15 to 25. Now we are running levels of 5 to 8, something like that. So the levels are pretty low. So it's not so much cyclosporine versus TAC. There may be a little bit of a difference. I think it's just that we are giving lower exposures now.
So folks in Pakistan, I mean, I don't know when last time I saw she got toxin-induced HUS. How about Pakistan? I mean, you see more often or not that much?
May I go for this? Actually, we do not have those definitive diagnostic tests that Shija toxin assays. So we cannot differentiate. There are so many other atypical HUS that may also present with diarrhea. Similarly, with pneumococcal infections, that I think they're almost as common as Shija toxin ones. But again, there are no definitive tests to be sure that this is an infection mediated. The only way for us to find out is if they would have recovered from their acute failure and acute hemolysis after 2 to 3 weeks. So those are the ones we think they have had because an infection mediated one. And usually they may not even develop that severe acute failure that would require dialysis. So it's just a bad infection that gets better a little later in the time, like 2 to 3 weeks, and they may not even know that they have had an HUS. So I think that is that answers your question. We don't know how much toxin we get.
I had one comment and 2 small questions. I'll try to be brief. Regarding the drug-induced TMA, I think the chemotherapeutic drugs and the other drugs that we usually talk about, the cyclosporine, tacrolimus, sometimes drugs like quetiapine, they are not really discussed. I have seen a couple of cases. It's hard to directly relate that quetiapine with the TMA, but there is literature on it. Secondly, 2 questions, one related to pregnancy. We have a theoretical evidence that in 3rd and 4th trimester, AMTS13 goes down, and in perpurium it stays so. So when we are talking about that 90% of TTP is antibodies directed against TTP. So are we talking about that antibodies are there, and along with that, there is a drop in AMTS13, and that has led to that TTP? Or we are, how do you differentiate between these two? Because we don't have assays over here. We have some theoretical knowledge regarding it. But what is the practical experience of yours in terms of peripartum TTP associated with AMTS13 and antibodies level? That's one. Number 2, there is a second hit theory regarding complement mediated HAS. Even regarding the peripartum HAS, they say that there is a second hit and it leads to that factor H and I mutations that are there, but they become on the surface and then they get back in a couple of years or may not go back ever. So how do differentiate between these two entities? In Pakistan, the problem is peripartum AKI, peripartum TMA, and peripartum TTP and DIC. They are so much in overlap, and there are so many patients who are not booked. They are from the peripheries, and they come to us in purpureal sepsis, and they turn out to be ANA positive, and they have a history of proteinuria. And when they come to us, they have schistocytes positive. They have PT-APTT deranged because of DIC due to some dye handling or something like that. And now we feel like that this sepsis has precipitated the TMA. And we have to treat that sepsis first. But by the time we get rid of the sepsis, usually the time frame of treatment of TMA is gone. How do you suggest we should do in patients like this one? This is the last question is most clinically important.
Okay, basically pregnancy is very common, cause and very common patient present with the TMA. So first of all, the timing is important also. I mean, there are different common conditions like where the patient you're dealing with the preeclampsia, or you're dealing with the HELP syndrome, or you're dealing with the TTP, or dealing with HUS. So basically, normally TTP can happen anytime during pregnancy. Most of the time, close to term, and sometime after term. I mean, HUS happens majority of time postpartum. The important factor is that you have to decide, because these two conditions, TTP and HUS, you don't have to deliver baby early because there is no advantage of doing that. Okay, while if you're dealing with HELP syndrome or you're dealing with preeclampsia, obviously the treatment is the deliver baby. So I mean, here we can use that times 13 level and to decide that what we're dealing with, that is a pregnancy or C-section or early term is important or not. I don't know how you deal without it, but I think if you have severe like HELP syndrome, like other enzymes, like liver enzymes are high, obviously you know that it's not TTP, and the treatment is delivering a early term is indicated. And also, I think just like I think that severity of the thrombocytopenia, I have seen many patients, very commonly see patient who has HELP syndrome, and we see patient with the preeclampsia, they don't have that low platelets count. If you're dealing really 30,000 and 20,000 platelets, you're most likely dealing with CTP. In that case, the treatment is accordingly.
Let me put a scenario and let me take guidance from all of us, because in Pakistan, we don't have ADAMTS13 levels and antibodies. I will ask Dr. Adil Manzoor if he's getting from somewhere. I'll try to get it done. A patient who is having a peripartum TMA, and we feel like, but there is a PT-APTT is deranged because of some dye handling or some uncareful handling through something, and there is an infection. So ANA is positive, and the patient got third trimester swelling with proteinuria maybe. So now in these scenarios, we won't be able to biopsy till we get rid of that infection. And the schistocytes are positive. Let's suppose C3 is also low. Would you recommend during that period, we can't give steroids, but should we start plasma exchange despite of the deranged coagulation profile? We are treating DIC, and should we treat the expected subclinical, or should I say, under cover of that DIC, there may be some TMA going on?
So you asked from
you or from anybody else?
Oh, so you asked from your Pakistani colleague, right? You asked from Dr.
I want to get the comment from them too, because this is a real life scenario.
Yeah, exactly.
And many of our colleagues are taking that controversial decisions. But in general, we do not like to discuss that because it's not really diplomatically correct to think like that. But This is a real life scenario. And daily we are receiving calls from our gynecological colleagues. And this is a scenario I think I am seeing.
I mean, I think what you don't want to miss, which you can kill, potentially can kill mother and obviously baby also, is if you miss TTP. I think in that circumstances, if you can range your plasmaphoresis, plasma exchange, even that was not correct. I mean, I think even that can increase the chance of infection. You can cover antibiotics. I think if you kind of rule it out, TTP, confidently, which is very difficult, almost impossible, I think I would go for giving patient a plasma exchange.
Can I just
May I
add
take a
here?
shot? Okay, Dr. Noman, please go ahead.
Yeah. Yes, I think we see a lot of patients. Actually, I wanted to discuss a case also. These are the patients we are seeing very frequently with the pregnancy-related TTP/HUS and infection on top of it. So what we do is we definitely treat the infection. And as Dr. West, you mentioned that if the platelets are quite low, then we'll have to make sure that we are not missing the life-threatening TTP, and the treatment will be the plasma exchange. So I think once you have covered the infection and we don't have the ADAMTS13 or if the complements are normal and we don't have the ANA which is negative or whatever, then you're only dealing with infection plus the TTP. And infection is very common in our scenarios because of various reasons. Now, if there are the complement levels are low, as Dr. Aurangzeb has mentioned, or the ANA is positive, then you're dealing with some kind of autoimmune disease. And again, if it is related TTP autoimmune, so then you have to go for plasma exchange. Then your threshold for going for plasma exchange will be very high, and that will be life-saving. I just wanted to, this was a comment that I wanted to discuss a case. It's about like 3 years now. This patient had TTP with the pregnancy, late pregnancy, and the primi gravida. And she had to undergo almost 20 sessions of plasmaphoresis and then rituximab. And then slowly, gradually, she improved. And now after like almost 3 years, she has normal kidney function, but she has very resistant kind of hypertension with almost 3 to 4 antihypertensives and her slightly increased echogenicity. Her platelets are normal. Now she wants to get pregnant, and because of all the social issues and everything, her question again and again is, what should I do? Now, I was unable to do the biopsy for her because she had such a resistant kind of hypertension that it just goes up very quickly, and then you have to pour a lot of medications to control it. So the question will be, what should we do for this patient? I'm sure, everybody will say, do the biopsy. But if I do the biopsy, I find, whatever lesions there, either, post injury FSGS or something like there, what should be the way forward there? Dr. West?
Yeah, first of all, I think biopsy might not be very helpful in this case because you cannot differentiate whether it's a TMA from what reason. So in that case, that's what I think. I mean, you can see that was the extent of damage to the kidneys are by biopsy, but otherwise they would not be very helpful. I mean, obviously she has a very high risk to develop the same thing if she gets pregnant again. So there's some sort of counseling, but again, it's not easy in some situation. I think in that case, maybe prophylactic plasma exchange or plasma. I don't think that this deficiency we have, I think it is acquired. Maybe I mean, I have to think about prophylactic plasma exchange to think about that, or maybe some immunosuppressant medication, maybe to prevent that, prevent it, like Rituximab. Have to think about this because you have to think out of the box to prevent that happening, because she would die. I mean, if second time if she goes through that, she already barely survived.
Yeah, so one quick thought here. So do you have access to von Willebrand factor activity?
No. Sorry?
Do you have access to von Willebrand Adams 13 activity?
No, we don't have. We don't have the assay here in Pakistan. That's the problem.
Right.
And I think once I tried to find out, it was like very costly or something. They used to send it out.
Yeah. And is she pheresis dependent now, or is she not on pheresis?
No. She's totally out of pheresis. She was normal. She had received 4 doses of rituximab, about 1 gram weekly. And then it's almost like more than 2 years that she's normal platelets, normal hemoglobin, and just a proteinuria and range of 2 to 3 grams.
Prophylactic rituximab, you can think about it, in my guess.
Well, the thing is that
could be a chance.
she's in full remission at this point. And so what is going to happen is when she goes through pregnancy, she's going to have a relapse. So it's a question of relapse. You can't treat a relapse before the relapse has happened. So I think giving her rituximab at this point is probably not going to change the outcome. But you probably need to be ready for the relapse. So obviously the ideal situation would be with previous kidney injury and 2 or 3 grams of protein now. Our risk of having a complicated pregnancy is going to be high. So adoption may be an alternative, but I understand the social pressures that our young females have to go through in our society. And under those circumstances, should she go through the pregnancy, she needs to understand she is going to be at a very high risk for a relapse of TTP. And at that point, you'll probably need to be very, very aggressive with early institution of plasma exchange, as well as deployment of rituximab at that time.
When I say that prophylactic, I said if you become pregnant, not now. I mean,
even during pregnancy, I think prophylaxis, you may not have a relapse. And so in that case, giving that rituximab is not going to be useful, but I think we'll have to monitor for her relapse.
That's a very good case and very good discussion. Irfan, do you think that how much chance you would take that patient? Because if she gets relapse, it might be severe than the previous one. That's a
right. But again, with plasma exchange, if plasma exchange is available, TTP can be treated. And so if she had TTP, if that's what she had, and plasma exchange is available, and she's in full remission at this point, and she wants to have a baby, this is a conversation to have. The best thing to do here is to avoid a pregnancy. But the question is, if Dr. Tarif tells her this, she's going to go and get pregnant anyways. And so it's better to control the process rather than not so. Now, the question is, at this point, if you give her rituximab, why are you giving her the rituximab?
Yeah, not now, if you become pregnant.
If she becomes pregnant, if you're giving her rituximab, why are you giving her the rituximab? Because she has not broken through yet. There's been no clonal expansion. She will break through during the around the 20th week, because at that time, what's going to happen is, because of dilution, her circulating von Willebrand activity is going to go down. She may break through with an antibody because she clearly had an antibody, and that is when she will precipitate the syndrome. So as soon as that happens, as soon as you see the first indication that the platelet count is dropping, you will need to institute pheresis and give a rituximab right up front at that time. But I think that's where the cost-benefit ratio is going to hedge at. But that's my opinion. This is a difficult situation. I'm perfectly open to hearing other opinions as well.
Yeah, I have one question from Dr. Naman. So how confident we at that time, since we did not measure the ADAM TS level in that patient at that time, how confident we were regarding the diagnosis of TTP versus the postpartum HUS? Because if there is postpartum HUS and this resistant hyper, then pregnancy, onset of pregnancy is going to be another complement amplifying effect.
Well, I mean, if everything was relating to TTP, the low platelets, the bilirubin and everything. And as you're right, we don't have ADAM TS13, but her response to plasma exchanges, when she improved her platelets, and then as soon as you start stopping the giving break into the plasmaphoresis, she just used to go down again to like 10 and 20s of the platelets. So, and then she responded to rituximab. And I think this is all that we can say.
It's not TTP, it looks like.
It looks like TTP.
Yeah.
What about pregnancy and rituximab? What's the experience? Do you use rituximab during pregnancy?
Yes, there's some series which have looked at that. It does cross the placenta. It's an immunoglobulin, and it does cause some neonatal lymphopenia. But in situations where it has been used, it has been okay. It's not like caused a crisis.
Yeah, we do Glomerular also, and Toxin also we use when needed during pregnancy.
Rituximab, I was sure about, but last time I checked, it was a general recommendation to avoid rituximab during pregnancy. For rituximab, I think the first patient who got rituximab, she was a female, if I'm not wrong. And
you can use other like azathioprine. You can Immuron, I think, also can use some kind of immunosuppressant medication which is safe. In that case, again, you have to think out of the box. I mean, here this is not like a regular situation. Which is safe during pregnancy, I think, like Immuron.
What to talk of to the fellows, but because generally we are recommending while we are giving rituximab that you should be avoiding pregnancy for 12 months. Is there any update on that, or should we still counsel on the same grounds?
Well, I think that comes from lack of data rather than preponderance of data. Rituximab, you can find rituximab in the blood 3 to 6 months after the initial administration. After that, it's hard to find it in the blood. So chances that somebody gets pregnant 6 months after exposure to rituximab will have translocation of rituximab through the placenta are going to be low. So I think 12 months seems to be a fairly reasonable, safe interval. But rituximab has been used during pregnancy under emergent circumstances, and a raging TTP syndrome would probably qualify as an emergent situation. So if we run into that, I would probably give her rituximab and be done with it.
Yeah, we got one patient who got rituximab and then she got pregnant against the recommendation within 3 months, and she recently delivered a very healthy baby. So that's a one case experience that I have, rituximab with pregnancy.
Just a quick update on a patient I actually put on the forum a few weeks ago. Nobody responded to that. I put that how you treat that hyponatremia. It's not like TTP case. I just want to, for the interest. 37-year-old patient who basically had a CA colon stage 4 and then got pregnant like a few months later, and she did not want to abort her baby. So that what happened that she knew that she has stage 4, but whatever reason, social reason or whatever, she decided that she would carry that pregnancy. And yesterday, we did a C-section, 28 week off, and after that, she said, "I'm going to hospice. I delivered the baby. My job is done." So you never know that what kind of thinking people have. She already has 3 children. It's not like her first child.
That's a very sad story. I think it's
yeah, really.
I have maybe I think it's in the interest of time. I'm sorry. The discussion is interesting, but I also feel that we need to be cognizant of everybody's time. So quickly, if I give me 30 seconds to present my case. So patient after first pregnancy, after delivery, 3 or 4 days later, came in 2 admissions, started with escalating blood pressure. Then platelets started to go low, it was in low one, like above 150 first, and then kind of between 100 to 150. Then blood pressure started to go very, very high. Kidney failure started while she was in the hospital. Creatinine was normal on arrival, and then we saw creatinine kind of going up and up. Blood pressure is going up and up. ANA is positive. Platelets now are kind of low 100. I think tricky case. Kidney biopsy, first they said all hypertension, then they changed, no, this is there is TMA going on the kidney biopsy. So we ended up sending her a genetic testing. She was positive for one of the big ones. So we started her on eculizumab. Very quick, robust recovery. Kidney failure took several months to resolve, but we saw that the urination increased and all that. So she's now on lifelong eculizumab. So for some reason, she missed a dose or two. And then by just missing that 1 or 2 dosage, we noted clinical markers of TMA. Her platelets went down again, and her creatinine had a small blip up. So now she is committed to this eculizumab lifelong. So she recovered from dialysis. She has now normal kidney functions. She still has less than 500 milligram of proteinuria, probably as a residual from the previous injury. But now, I mean, she's back in life with this infusion lifelong.
That's a classical case of postpartum HUS. I mean, very nice case. And also, there are different theories that why it happens postpartum, majority of the cases. I think in this case, the placenta provides some protection against that HUS, and when the placenta is not there, and then can cause that. Other question I have: did you check I mean, antibodies against the factor H or anything like this? If that is positive, my question is there any role of rituximab on that case along with eculizumab?
This was checked, and I think there was a discussion about it, and I don't recall all the details. Maybe I can go back because we have this case in the case report, and I can share. But there was a discussion: should we start with rituximab and then eculizumab and all that? I think there was a lot of discussion, pathology and us and hematology. Everybody was engaged, and everybody said plasmaphoresis, rituximab, eculizumab. But the final word was that eculizumab gave her the really response, and that was like real treatment. Everything else was just because you're shotgun approach. You're just kind of trying to, you have something in your armamentarium and you're just using it.
I mean, surprisingly, it's easily approved also, this eculizumab, because the drug company know that if they don't approve, then they can have a lawsuit.
The genetic testing took long. The specimen when sent, the first specimen was lost somewhere. So that was kind of, the other, and then it was kind of, that Christmas, New Year, long break, the test is lost once or twice. So it took us some time to reach to the final diagnosis.
But that's actually a very, very good point, that one must never, 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 ever wait for the genetic test to initiate therapy. So you need to make a call, you need to start therapy. You can get the gene testing later, but you can't make the diagnosis based on gene. You had everything you needed to make the diagnosis. So you needed to start treatment at the time when you had the patient with thrombocytopenia and renal failure and thrombotic microangiopathy on the kidney biopsy. The only thing that you need to exclude is there TTP or not? And based on the story that you're telling me, there's a 0% chance, well, less than a 1% chance that this would be TTP. The plasmic score of this person is very high. And so right off the bat that this is going to be HUS. You need to start treatment. I mean, this is for the fellows listening on, sometimes there's fog of war, but one must never pen the treatment decision waiting for gene testing. It'll take 2 weeks, 3 weeks. You'll have irreparable damage to the kidney in that period of time. You need to start treatment straight away. And you actually saw the impact of missing treatment for 2 weeks. They developed TMA just like that.
Just so I was listening to a webinar on this topic, like somebody from Australia, he was saying that, okay, we have sent the genetic testing to California, it would take 4 weeks to come back. So from Australia, they sent to California, genetic testing. So it takes long. Again, you don't wait for genetic testing to start treatment.
Okay, any final thoughts, final comments before we conclude the session? Avais, do you want to say something?
No, I mean, really, I learned more. I mean, this is a very good discussion, and particularly, I always interested in different experience. I mean, I think I was thinking about that. Our colleagues in Pakistan, they are all-rounder. Okay, we are kind of either bowler or batsman. You can say that. Okay, I can treat certain things like maybe hypertension or some other things. They treat everything.
12th man.
they treat everything. I mean, it's really kudos to them. I mean, kudos to them. They treat everything. So that's why I try to learn from them, their experience. That's always really very enjoyable. Thank you for that.
Thank you, Wes, for a wonderful presentation. This is a really complicated topic, and you really, put it out very, very clearly and concisely. Thank you for that.
Thanks for your input also. Thank you. Okay.
Thank you.
Thank you very
very
much.
much.
It was an excellent session.
Thank you.